take a few minutes. So if we have the permission of the chair and the speaker both, can we take this forward?
Yes, please.
Lovely. Great. So good evening, everybody, and welcome back again to the new edition of the D.Y. Patil postgraduate lecture series. We are very, very grateful to our faculty. Can I ask the host to mute everybody, please?
Yes, Dr.
So it's a pleasure and privilege to have with us today Dr. Sathya Rao, all the way from Victoria, Australia, to teach us a little bit about the borderline personality disorder issues that we grapple with all the while, and it's as complex a disorder in psychiatry as one can possibly have, despite of all the hype around the traditional schizophrenias and bipolars, where though they are confounding, a lot is understood and known, and treatment guidelines are far more clear, as opposed to disorder such as borderline personality, which has always been a confounding factor for most of us. We deal with it a lot, but we don't know how to go about it. So today we'll probably learn a few more tricks, thanks to our eminent speaker. And we are grateful to have Hinal with us back again. Dr. Hinal Shah is a professor at the Department of Psychiatry at Nair Hospital. And she is somebody I've known for a very long time. She is truly a very, very humble person, but a great teacher, a great inspiration to all her students. I know it because I've known her personally as a co-faculty as well as a teacher for many of her students who now work with me, or I have had the privilege of associating with. And I think the true mark of a clinician is the regard that her students might have for her. So by that token, Hinal is right up there. And thank you very much, Hinal, for taking the time and being with us on this platform again today. Hinal is interested in medical education. She's interested in child and adolescent mental health. She has been instrumental in starting and running quite a few programs at Nair Hospital and other places in her earlier stint. So we welcome you on this forum back again, Dr. Hinal Shah, and I request you to take over the proceedings for the evening. And I'll see you later in the day towards the end. Thank you. Over to you, Hinal.
Hello, Rashmin. Nice to be here once again, and to be here to hear such a distinguished speaker such as Dr. Sathya Rao. And you know, the funny thing is, it is called the PG lecture series, but I know that it goes much beyond the PGs. Forget the PGs. Many of us practicing psychiatrists are also here to hear all these words. And I must congratulate Rashmin before I really go ahead, that he has single-handedly and persistently continued this effort and got varied speakers from various places to share these nuggets of information. So kudos to you, Rashmin, for that. Now coming to today's topic. When I think about it as a student, when I was a resident in KM Hospital, I remember, I used to be worried, will he come today or not? And him was one patient who came so often and threatened to slit his wrist unless he was admitted, or threatened to, get a razor blade and talk about all the problems he's having. And every time it used to be a dilemma. Should I admit him or not? And, this borderline patient that we had diagnosed was so tough to manage. Scene 2, as a faculty in KM Hospital. So I was treating a patient with borderline personality, and, she in her tumultuous way would say, today I'm never going to take treatment from you. And a few months later would say, you are the best doctor. And this, went on back and forth. And then I got transferred, went to another hospital. And a few years later, I see her niece. again with borderline personality disorder. And I realize now the aunt is grown older, much better, but now I'm dealing with the second one who is going tumultuous and at the end of this month is going to deliver a baby. And then Rashmin said there is a talk which says it's very simple to manage borderline personality disorder. Now that was a bit. If anybody can tell me that there is a way to do that simply, I would be really intrigued. And we are so lucky to have Dr. Sathya Rao with us to really discuss this, all the way from Australia and very specialized in this work. He's a clinical director of Spectrum Personality Disorder Services for Victoria, Vice President of the Australian Borderline Personality Disorder Foundation, Adjunct Associate Clinical Professor at Monash University. He has a passionate advocate for borderline personality disorder, keen interest in developing simple, affordable, doable models which all of us clinicians can use. And he's so well known that people go to him for secondary and tertiary references to figure out what to do next. He has been a member of the Guidelines for Development Committee for the National Health and Medical Research Council of Australia, published extensively, and in his recognition of outstanding services to Victorian psychiatry over all these years, he has been awarded the Meritorious Service Award. And in recognition of his contributions to psychiatry, he received the award of Medal of the Order of Australia. Wow, that's wonderful. But not to forget, he's actually one of our boys from Nimhans who has gone there and kept the light shining for all of us. Wonderful to have you with us. And now I'm going to hand it over to you. Sir will speak to us for 45 minutes to 1 hour. You can keep chatting, putting your questions in the chat box. And if there are any burning questions, maybe you can unmute them. Otherwise, usually we reserve the questions for the end of the session. And now I'm sure we're all eagerly waiting to understand which are the simple and practical ways that we can manage borderline personality disorder. Wonderful to have you with us, Dr. Sathya Rao, and over to you.
So thank you, Professor Shah. You really made my day by calling me one of your boys. I'm one of your boys. I am. I actually graduated from Nimhans way back in 92, 91, in fact. And I learned psychological treatment, psychotherapies in Nimhans. And in the last 25 years, I've been practicing in Australia, predominantly in the field of borderline personality disorder. Before I get started, my sincere thanks to Professor Cholera as well as Professor Shah for inviting me for this lecture. So let's see. I'll try and talk for about 35 to 40 minutes, but I'm happy to be interrupted. I'll be guided by Henil Shah as to how the questions will be moderated. Let me try and see if I could share the slides. Sorry again. Tell me whether you are able to see my slides.
Yes, now we are able to see your slides.
Perfect. So I've titled this talk Borderline Personality Disorder, a treatable disorder with good prognosis. In fact, there is research to show that not only it's a good prognostic disorder, the prognosis is much better for borderline personality disorder compared for schizophrenia and bipolar disorders. So the science of personality disorder has taken a center stage in mental health in the last 20 years. And as all of you know, personality disorders are the most stigmatized, misunderstood, and undiagnosed conditions in psychiatry. A generation of mental health professionals have not been trained to treat and manage people with personality disorder. This is across the globe. And right now, we have evidence-based treatments for borderline personality disorder. There's no evidence-based treatments for any other personality disorder at this stage. Now, in its simplest form, personality can be defined as a person's characteristic style of thinking, feeling, and behaving. Of course, we have a much more complex definition within the DSM-5, which all of you are quite familiar with. Personality disorders are extremely common. The prevalence can be as high as 11%. In psychiatry, in the outpatient population, about half of the people have a diagnosis of personality disorder. The highest prevalence is seen in criminal justice system, in the prisons. And if you look at the suicide rate for borderline personality disorder, it is 10% of all suicides for all reasons is accounted for personality disorders. Unfortunately, BPD and personality disorders in general have had very limited recognition as a public health issue. This is the DSM-5 classification of personality disorder that all of you are familiar with, where we divide into 3 clusters. And the borderline personality disorder is in cluster B. However, this sort of a classificatory system is currently becoming obsolete. In the new classification in the ICD-11, we no longer make this differentiation of the subtypes of personality disorders. In fact, it is now a single unitary diagnosis of personality disorder. And we don't talk about subtypes. We only talk about severity, which is mild, moderate, severe. And we can specify trait domain qualifiers if required. And borderline personality disorder is a borderline pattern. So in ICD-11, we'll call it as personality disorder, borderline pattern if required. Unfortunately, as all of us know, vast majority of the people with personality disorders do not receive any meaningful care or treatments. And Dr. Shah very beautifully explained some of the symptoms of borderline personality disorder and the challenges in caring for them. In most countries, we don't have mature models of care, and vast majority of the people with borderline personality disorder as such do not receive meaningful care or treatments. So of all the personality disorders, BPD is the most commonly diagnosed. It is the most severe of personality disorders and contributes to 95% of all personality disorder related suicides. We just did a study in Australia and demonstrated with the coronial suicide data. BPD, as you know, is one of the most stigmatized disorders even within psychiatry. Look at the clinical features. Instability is one word I want you to remember. BPD is all about instability. Instability of emotions, instability of relationships, instability of self-identity. And impulsivity, a sense of emptiness, a constant fear of abandonment, a fear of rejection, suicidal behaviors, and non-suicidal self-injury behaviors, which are a characteristic signature symptoms of borderline personality disorder. We could also have micropsychotic episodes and dissociations as such. One of the most difficult symptoms of borderline personality disorder, which causes significant psychological pain for our patients, is the sense of chronic feelings of emptiness, nothingness about them. That's sometimes described as identitylessness. Often patients will tell you that they are nobody. They feel empty all the time. Nothing can fill them. They often try and fill that emptiness with using substances or repeated relationships or changing their identity into various mimic various people. Despite all of that, they're left with a gnawing sense of emptiness, which can be very painful, which is often leads to self-injury and suicidal behaviors. This is the DSM-5 criteria for borderline personality disorder. I'm not going to go through this list. As all of you know, there are 9 criteria listed, of which you need only 5 to make a diagnosis. So therefore, So there are no weighted criteria. So therefore, you could potentially have 256 subtypes of borderline personality disorder if you do your maths permutations and combinations. This is John Gunderson, the late John Gunderson, who actually gave the name BPD and launched it into DSM-3 in 1980. This is a statement that BPD is to psychiatry what psychiatry is to medicine, and I think that this aptly describes the current situation. BPD is extremely common, 1% community prevalence, up to 20% in mental systems, 10 to 15% of all emergency presentations for psychiatry, and in GP care, primary sector, it's 6%. Despite these numbers, there is a significant problems in resource allocation for borderline personality disorder. I have some colleagues who literally put a board that they don't treat people with personality disorders, but still they can't escape getting referrals for borderline personality disorder. Often they get referred in the guise of bipolar disorders or depression. So this is a serious issue. When someone gets a diagnosis of borderline personality disorder, their lifespan is reduced by 20 years. This is not accounted by suicide because they don't look after their physical health care. The suicide rate is 10%, as I mentioned. The rate of non-suicidal self-injury, this is cutting, burning, taking minor overdoses, that's up to 85%. Often BPD is thought to be a diagnosis that is seen only in women, which is not true. If you look at the community prevalence studies, the gender distribution is equal. Unfortunately, men are often given a wrong diagnosis of antisocial personality disorder, and often they'll end up in drug and alcohol centers and prison settings. Again, although the most common onset is during the teenage years, BPD can present for the first time at any time in the life. Late manifestation of BPD is well reported. In fact, we have reported a paper just this year. We have diagnosed people with BPD for the first time at the age of 70, 76. I have treated someone at the age of 80. BPD often co-occurs with other psychiatric conditions. BPD has been termed as the king of comorbid kingdom. So wherein lies the additional difficulty? Although it has got multiple comorbid disorders, unless we treat BPD, the other co-occurring disorders don't go into remission. A classic example is clinical depression. If people have depression and borderline personality disorder, if you only treat depression with medicines, antidepressants, even ECT, those depressions don't respond to treatments because borderline personality disorder offers treatment resistance. Whereas if you treat borderline personality disorder with psychological treatments, both BPD as well as depression go into remission. Again, there is a misunderstanding that BPD is caused by trauma and that it is a trauma disorder. There is a temptation to call it as a complex trauma disorder or a complex post-traumatic stress disorder. No doubt, trauma is very, very common in BPD. Up to 80 to 90% of them can have trauma, but also 20 to 30% of them don't report any trauma. So trauma is a risk factor, but it is not causative. Correlation, yes. Causation, no. Complex PTSD, which has become a new diagnosis in ICD-11, although it has been known for 25 years, but it has become an official diagnosis only since the beginning of this year. So, which was part of BPD before, now it has been taken out as a separate diagnosis. So, to make a diagnosis of complex PTSD, as you know, you need to have PTSD in the first instance, plus 3 other symptoms. That is emotional dysregulation, interpersonal difficulties, and negative self-concept. All these 3 are, again, symptoms of borderline personality disorder, criteria for borderline personality disorder, as you know. So these 3 criteria plus PTSD gives you a diagnosis of complex PTSD. As you can see, this is not the same as borderline personality disorder. Let's skip this slide. This is again another way of trying to demonstrate the differences between PTSD, complex PTSD, and borderline personality disorder. I'll let you have a read at your own leisure. Now, so what causes borderline personality disorder if trauma is not the cause? So borderline personality disorder is caused by biopsychosocial factors. Environmental factors such as attachment difficulties, trauma, bullying may all contribute to development of borderline personality disorder. The contribution of bullying to the causation of borderline personality disorder has been less well understood so far. And there are also significant biological abnormalities. The heritability effect for BPD is nearly 50 to 60%. So half of the causation for BPD comes from genetics. We also know that the amygdala is abnormal. It is hyperactive and hyperreactive. And as you know, amygdala is the seat of emotions. So these patients they're very, very sensitive to emotions. They react with emotions with high amplitude very quickly and very rapidly. The reaction time is very small. Also, the cortical controls, which is supposed to regulate the emotional expression and the emotional intensity, that is abnormal. So the corticolimbic system is not very effective. Therefore, you have a problem where emotions are running wild, but the regulatory mechanisms are the problem. That's why you see BPD patients having dysregulations and given to rage. And once they have heightened emotions, it's hard for them to calm down very quickly. There is also abnormalities in the anterior insular part of the brain, which again is correlated with the profound incapacity for cooperation. So as you can see, there are biological abnormalities in borderline personality disorder. Now, if you compare the emotional system of a person with borderline personality disorder to a car, so we are talking about an abnormal hypersensitive accelerator and very poor brakes. What I mean by that is, if you compare the accelerators to the amygdala, the emotional system, they are very, very sensitive accelerators and very poor brakes. Brakes are the cortical control mechanisms. As you can imagine, if somebody is driving a car with very, very sensitive accelerators and poor brakes, they're going to drive erratically. But when you look from outside, one can't make out the problems in the mechanics. They're going to judge the person who is driving the car. So that's the patient. Now, our job as clinicians really is to be a driving instructor, sit in that car, which has got very poor brakes and sensitive accelerators, and teach the person how to drive that car. The evidence shows that once the patients learn how to drive such a car, and they do learn, and it takes about a year or two, once they learn, they actually can drive the car quite effectively. The trouble, though, is that it is so anxiety-provoking for the clinician to sit in that car. They often use their dual control mechanisms, which is putting the brakes every now and then. So if you don't allow the person to drive such a car and guide them gently, they're not going to learn how to drive. So I'm talking about admissions and medications. So that's really the summary of the whole treatment, really. Now, also, having borderline personality disorder, as I just demonstrated to you, is not the person's own fault. It is a disorder of the brain and the mind. I feel that this is the most important slide because it's often very difficult for clinicians to believe that this person is not able to control their emotions, control their behaviors, control the way they're demanding and behaving. So therefore, automatically we start judging them, we start demanding them to behave properly, as if they have the ability to do so. Whereas when someone has schizophrenia or bipolar disorders, we don't make such demands. So that's the basic difference, I believe, when it comes to treatment of people with borderline personality disorder. So the point is, these patients can be difficult to treat, but it is the illness that produces the behavior, not the person. Remember the car analogy I gave you. Often people judge the car driver, not the car. The problem is in the car, not the driver. So I'll skip that slide. When it comes to treatment of BPD, unfortunately, we still don't have any psychotropic medications that are patented or indicated for treatment of borderline personality disorder. There is no evidence. Psychological treatments, of course, have enough and more evidence. And when I last counted, there were about 30 randomized controlled trials. So there is ample evidence to say that if you do treat people with borderline personality disorder with evidence-based psychological treatment, not just counseling, not just being supportive, but actually doing BPD-specific psychological treatment, they do get better. That doesn't unfortunately stop us from prescribing medications. In fact, we prescribe more antidepressants to people with BPD than people with depression. So that there is a paper actually showing that. I'm going to try show you a video which sort of highlights some of the difficulties we have in treatment of borderline personality disorder. If someone could just kindly let me know if you can see the video. If you can't, please alert me. Give me a second. You just go to. Can you see this slide at all? Can you see the video?
Yes, we can.
Thank you.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail.
See, you're not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Oh, come on. If you would just.
Don't.
That's basically illustrates one of the clinical problems that we have while working with people with borderline personality disorder. Often the tendency is to try and fix the problem, because the solution to the problems that people with borderline personality disorder present to us seems very obvious to us, like the nail in the head. But the issue is that the person is not in a position to listen to our solutions until we validate them, until we understand their perspective. Once we understand the perspective, then they're willing to work with us and remove the nail. But it can be very hard because in practice, the solutions are going to be so obvious to us. The temptation is going to be often to keep fixing it. Just give me a second. I'll get back to the slides. Give me a second. Okay, I'm hoping that you can again see my slides. Now, this is a list of all the
Yes.
evidence-based. Thank you. This is a list of all the evidence-based psychological treatments for BPD. Now, dialectical behavior therapy being the most common and most popular. But however, all the treatments are equally effective. And these are a couple of Australian contributions. And we have actually at Spectrum, we have adopted the acceptance and commitment therapy to the borderline personality disorder treatment. This is a list of all the generalist treatments, which are again evidence-based. Now, all the specialist treatments, all the evidence-based treatments, all equally effective. There's really nothing much to choose between each other. And efforts have been made to look at the common factors in all of this specialist and evidence-based treatments, and also looking at all the guidelines and the international expert opinions. So what it seems like is the integrated common factors, a stepped tiered approach seems to be the best way to go about in Australian mental system, in fact, more globally. At Spectrum, we have developed a 10-session and 20-session treatment, which is freely available to download from our website. I've given you the links. Feel free to use it. We have also developed a 10-week intensive group treatment where we deliver 80 hours of psychological treatment in 10 weeks' time. We have published that paper. Again, even within 10 weeks, we can reduce suicidal ideation, self-harm, and suicidal behaviors. So, in summary, the prognosis for borderline personality disorder is good. Psychological treatments work. Most patients get well. Many can recover. Most patients stop wanting to kill themselves. So BPD is a good prognostic disorder compared to previous beliefs. This is one of the outcome studies, a 16-year outcome study. It shows that 10% of the people can go into remission in 6 months, quarter of them in a year, half of them in 2 years. As you can see, two-thirds of them can recover, not just go into remission in 16 years. Look at the relapse rates. Only 15% of them relapse. Compare that with schizophrenia, bipolar disorders, and depression. As you know, in depression, 50%, 50, people relapse. The prognosis is much better when you have administered evidence-based treatments, such as mentalization-based treatment and dialectical behavior therapy or GPM. In these treatments, two-thirds of them go into remission in 1 to 2 years' time. Look, and again, another way of looking at remission and recovery, again, in 16 years' time, you can look at, in 16 years' time, 99% of the people can go into remission. Now, this sort of a figure you can never see for any other psychiatric disorder. Unfortunately, it has had so much of a bad press because the treatments are psychological in nature, not medications. It has not become popular yet. Okay, now, is there a pill for borderline personality disorder? As I told you, there is no medicine which is patented or indicated. Now, a word of caution, 25% of the patients with BPD can attempt suicide, not self-injury, suicide with prescribed medications. Therefore, we need to be careful while prescribing, if you do prescribe, because there is no evidence for prescriptions. Now, the international consensus is that about 20% of the intensity of the symptoms may be reduced by medications. So therefore, you can use medications to some extent, but expectation needs to be very, very less. Now, there is very limited data to support some of these medicines. I do use quetiapine in very small doses, 25 to 150 milligrams for crisis management, but usually it is only for 1 to 2 weeks' time, not for ongoing treatment. It doesn't bring about any changes in the fundamental nature of the disorder. It is only used for crisis. Lamotrigine and topiramate, there is some evidence that it reduces anger, aggression, and mood instability. Lamotrigine can start working even from the dose of 50 milligrams, and it can be given up to 200 milligrams a day. And this is my most popular drug, lamotrigine, because it doesn't cause weight gain. It is quite a silent drug when it comes to side effects, except for the dreaded Stevens-Johnson syndrome, which can occur in a very small number of patients. Aripiprazole in very small doses again can be used for short-term crisis management. Again, so is fluoxamine. Fluoxetine was popular in the past, now it is no longer used. Olanzapine can be useful to some extent, but again, because of the weight gain, we don't use it at all. This is my most popular prescription, which is the omega-3 fatty acid. There is a preparation called the Ultra Clean. I don't have any shares in the drug company. 4 capsules a day in the combination of 1200 EPA and 800 DHA. That produces some reduction in depression and aggression in borderline personality disorder, might reduce the overall severity of PPD symptoms, according to a couple of studies. Because it is so safe, I do prescribe this commonly. Now, the future, we can look forward to an amygdala modulating agent, maybe the psychedelics, which might have an answer to some extent. TMS has been reported to be somewhat useful. Again, the evidence is lacking. Again, are there deep brain stimulation techniques or CRISPR gene editing kind of techniques in the future? We don't know. Now, can interested clinicians provide psychological treatments for BPD if they're not trained in psychotherapies specifically, or not trained in one of the specialist BPD therapies? Because to learn specialist BPD therapies such as dialectical behavior therapy or mentalization-based treatment, it takes years. And also it's so expensive. And I don't think that is a solution for all clinicians. These are the best practice guidelines for borderline personality disorder, the global guidelines. Now, if you look at the summary of all of those guidelines, if you want to make it really simple, these are the summary of principles. Number 1, we need to provide psychological treatments to get our patients well. Because it is going to take time for them to get well with psychological treatments, and meanwhile, they might attempt suicide. We need to help them manage their distress and keep them alive with structured crisis interventions. They are going to have co-occurring disorders. I told you that the BPD is called the king of comorbid kingdom. Therefore, you may need to treat some of the co-occurring disorders if they're not going to remit with psychological treatments alone. We need to look after their physical health and well-being, because 20-year reduction in lifespan. It's very important to improve the quality of life. So jobs and relationships, please attend to that. And educate and support families and carers. Really simple. It's not rocket science. I'm sure all of you are already doing this. This is just a validation that what you're doing is what is required for treatment of borderline personality disorder. You just need to persist. So if you know enough to avoid being harmful, you can surprisingly be helpful in the treatment of borderline personality disorder. This actually, again, captures the essence of the treatment. But I'm not saying that any one of us are going to deliberately be harmful. But without our knowledge, we can be harmful in the way we interact with people with borderline personality disorder. If we can avoid that, that in itself can be quite helpful for people with BPD. It is the key to successful treatment with BPD is for the clinicians to manage their own emotional reactions. When you work with people with borderline personality disorder, we are all going to have emotional reactions. That is a given. Our emotions are going to get triggered. If we can become aware of our own emotional reactions and avoid reacting with their emotional reactions, we can actually do a lot of good. So another most important ingredient of effective psychological treatment is ongoing therapeutic relationship with the clinician. So it's important to see the bare minimum frequency is once in 2 weeks. Once a week, it is would work really well. If you can see a patient once a week for 1 to 2 years and administer the most simple psychological treatments, you can actually surprisingly get your patients well. But tolerating the ups and downs and the tumultuous nature of the emotional roller coaster going to be hard. If we can work through those things, patients tend to get well. So my take is that all of you can do psychological treatments for borderline personality disorder, and it is absolutely not a rocket science. In fact, we have done harm by selling the BPD treatments, BPD psychotherapy as very complicated, as a rocket science, which has actually scared generation of clinicians not to take up treatments. This is John Gunderson, who spent nearly 50 years working with people with borderline personality disorder. He's no more now. He is the one who gave the name BPD. He says that most clinicians can effectively treat most patients with borderline personality disorder. This is one of my senior colleagues. She makes the statement that effective psychological treatments for borderline personality disorder can be provided by clinicians who lack specific training in psychotherapies. So what is summary of the essential principles? First and foremost, we need to make a clear diagnosis of BPD and delineate its comorbidities, make an assessment of risk, and understand why they are self-injuring or why they are suicidal. So it's just a direct question, a non-judgmental direct question saying that you do self-injure, how does it help you? Why do you do that? Patients will often tell you that they self-injure because they are trying to regulate their emotions. So developing a joint crisis management plan, which is patients and us together developing a plan. In fact, it can be done on your letterhead. And providing psychoeducation to the patients, setting up a treatment contract of care, and avoiding hospitalization as much as possible. Remember that car analogy I gave you. Remember, if that car was just parked in the garage all the time, that person is not going to learn how to drive. That is how to navigate life. Similarly, if you keep hospitalizing patients, they don't learn how to live in the real world. So the approach needs to be collaborative, and we need to balance validation and change. What I mean by that is sometimes we can fall into the trap of being very nice to the patients all the time and being, of course, we need to be nice to the patients, but if we just keep on agreeing to whatever the patients are saying, that is validation, you might not really bring about the change. So we need to bring about the change skills and the validation skills on a balance. So we need to teach them skills to manage their emotions, manage the crisis, manage the interpersonal dynamics. And we need to put a focus on emotions, our own emotions, and the patient's emotions. We need to teach the patients how to regulate their emotions. And often patients with BPD don't connect their actions with their emotions and feelings, which may be very obvious to us, but it is not obvious to them. So we need to help them connect the thoughts, feelings, and emotions and behaviors. We need to foster self-agency and self-responsibility, and we need to treat them like adults and not to fragilize them too much. We need to all the time pay attention to the therapeutic relationship, keep a warm therapeutic relationship. It goes a long way in getting them well, and seek supervision and speak to your colleagues if you're experiencing significant anger and emotions against your patients. Clinicians who are trained, who are willing, who are active, who are hopeful, and enthusiastic seem to do well in the treatment of BPD. There's some evidence to say that. Encourage your patients to get a life, apart from hospitals, apart from medicines, apart from crisis, to get into jobs. And if they're in good relationships, help them to keep those relationships. If they're in problematic relationships, help them to get rid of problematic relationships and negotiate new relationships. So this is an acronym, Jacobs, for the cognitive distortions that you commonly see in borderline personality disorder: jumping into conclusions, assumptions, catastrophizing, overgeneralizations, black and white thinking, shoulds and musts. This is all very common in BPD. And if they do have, it's important to point out to them. A couple of words about risk assessment. Risk assessment and management of suicide is very different in borderline personality disorder compared to other psychiatric disorders. The reason being, when people with borderline personality disorder talk about suicidal thoughts, they've often had it for years and years and years. They've had it almost every single day. That's different to people with schizophrenia, bipolar disorder. When they are suicidal, they're indeed suicidal. With borderline personality disorder, chronic suicidal feelings are coping strategies and often might not mean suicide. You need to differentiate between acute suicidality and chronic suicidality in borderline personality disorder. Acute suicidality is, of course, the suicidal ideas, acts which are aimed at death. Whereas chronic suicidality is any suicidal act or threat which is repetitive in nature but does not aim to end life. Often, BPD patients are unaware if they're acting on a suicidal impulse or self-injuring to regulate their internal or external world. So therefore, BPD patients are unable to tell us whether when they do something to hurt themselves, whether that was intended at dying or not. So if patients are unable to verbalize, there's no way we are able to make out whether they're suicidal or not. Otherwise, we start judging them, and that can become problematic. Unfortunately, there is no science to help us distinguish between non-suicidal self-injury behaviors from suicidal behaviors. Now, I'm going to stop here and see if there are any questions. Thank you. Over to you, Dr. Shah.
Hinal?
Can you hear me?
Yeah, we can.
So
Hinal?
happy to take any questions now. Thank you.
Can you unmute Hinal, please? I'll request the tech support, Nitish. I think Hinal has been accidentally muted. Hinal? Nitish, can you please unmute Hinal?
Yes. Hello.
That was a fabulous talk, and I particularly like the analogy of the driver and the car, Dr. Rao, because that is so accurate and it is such a relatable kind of a description, not just from the perspective of being able to understand the cases, but also to be able to explain so much of what they go through. So it's a brilliant analogy, and I think it's got various layers to it, which I think as we see the case and as we relate to this analogy, we'll probably discover more and more. So absolutely brilliant. And it also is a revelation that we probably have some hope of learning to do therapy as well, rather than having to depend entirely on our friends from the therapy world. So it was quite an enlightening thing, and it encourages me to read a little bit more, to learn a little bit more. That's probably what we need.
So thank you, Professor Kolra.
Please call me Rashmi.
Thanks, Rashmi.
I think Hinal is yet not unmuted for some reason. In the interest of time, I will just go through a couple of questions till she comes on board back again.
Sure.
Priyanka said that she really liked the video of the nail in the head, but however, it also is well known that we can't really help someone who isn't willing to seek treatment. Is there a way to get around such patients with BPD who are not willing to seek treatment or even agree to seek consultation, completely denying if there's any issue at all?
So that's really a really great question. That's really a problem. Yes, the people who need the treatment the most are the ones who don't access the treatment. Now, one wonders why, though. are the treatments that we have got to offer for those patients are not the treatments that they are seeking for. So if imagine a person, if that person has been told repeatedly that they're behaving badly and they are not, they have a mental illness and they have to see a psychiatrist because they're behaving badly, they're doing things badly, and they have to stop self-harming, stop being suicidal. Obviously, the person is not going to be willing to seek treatment from us because they see us as people who are invalidating them. So I think the trick is to, if we can get a window of opportunity, and if we are able to uh, work from their point of view, at least in the initial sessions, often they tend to come back for treatment. Remember the nail the nail in the head analogy. So they, unless the person is validated, they're not in a position to remove the nail. So the trick is to validate them first. So if they're not even coming to the psychiatrist or the psychologist, so probably you can work with the family to validate them enough to make them come to the treatments.
Thank you, Dr. Sathya, for a wonderful presentation. And I think you made it really sound something that is doable and workable for most of us. Going to another question that has come also is that how do you deal with conversion symptoms in patients with borderline personality disorder? So this has been asked by Dr. Rakesh Belgudri, that how do you really deal with all of this?
Look, again, see, if you look at conversion symptoms and dissociation symptoms as really coping mechanisms, defense mechanisms. So it is the central problem is the psychological pain, the emotional distress. That's the core problem. Now, there's the psychological pain can be expressed in the form of a conversion symptom, or if the pain is so significant for short periods, people can experience dissociation. Then again, manifestations. So the suggestion is not to really get too preoccupied with the symptom, but go for the psychological work. So again, one would look at validating the conversion symptom. Let's say that it is a pain as a conversion symptom. So we validate the pain because the pain is real. It doesn't matter whether the pain is coming from a physical origin or a psychological origin. The pain experienced by the patient is real. So we validate the pain, but we don't stop there. We go for the root cause of these the pain, the somatic symptom, and work with the origins. Then patients tend to get well.
Thank you. That's really a very important point for all of us to think about, that, not letting the patient get us riled and our counter-transference. I think with conversion and borderline, that tends to happen very often. So being aware of it and being able to accept that person, accept and acknowledge the pain is one of the most important things for that person to come. If sir is saying that, if you can see the patient once a week, it is important for us to have a rapport that encourages the patient to come once a week, and he or she would feel like coming. So I think keeping that in mind is very important. Another question that has come is about borderline personality disorder and adult ADHD. Do you see that often? And if so, what would your take be in the management and the intervention for that?
That's a really good question again. Now, childhood ADHD is a risk factor for development of borderline personality disorder in adulthood. That's been quite well established. Also, there are overlapping symptoms between ADHD and borderline personality disorder. Emotional dysregulation can be common to both. Impulsivity can be common to both. Anger discontrol can be common to both. Even self-injury can be common to both. Some of the symptoms with which you can delineate borderline personality disorder and more confidently diagnosed borderline personality disorder are fear of abandonment, emotional dynamics. That's much more characteristic of borderline personality disorder. And a chronic sense of emptiness. And the interpersonal dynamics of idealization, devaluation, which Hanel Shaw very clearly explained while she was giving the introduction, those symptoms delineate BPD from ADHD. And BPD and ADHD can also co-occur in about 10 to 20% of patients. If that happens, continue doing psychological treatment for BPD. And if you feel compelled, prescribe some medicines such as stimulants for ADHD.
Sure. Thank you very much. So, just as we are saying that, that instability is common, we also said that chronic emptiness is common. So Malvika is asking, how do you then differentiate dysthymia from BPD? And when would you really think of giving medications for that chronic dysthymia kind of symptoms that you see often in patients with borderline personality?
Great question again. Chronic dysphoric symptoms are part and parcel of the borderline personality disorder diagnosis. You don't need to give a separate diagnosis of dysthymia. So that's the first answer. Secondly, if you do prescribe medicines, you're not going to see much of a change. So those depressive symptoms, which are integral to borderline personality disorder, don't respond to antidepressants. For that matter, even biological depressions, clinical depressions don't respond to antidepressants or ECT adequately, unless we do psychological treatment for BPD. There are plenty of studies that have been done, multiple randomized control trials that have been done to describe. Then there's one more question there about emptiness, saying how to manage constant feelings of emptiness. That's one of the most difficult symptoms to work with. A couple of examples that my patients have given me when they're describing emptiness is, one patient said in a very gory way that if you really cut me open, you're not going to see any flesh or blood in my body. You're just going to see black. That's how I feel. There's not even a flesh or blood in my own soul. It is just black, dark. So that's a very painful description. Often you see this emptiness or nothingness or nobodiness or identitylessness in people with BPD if they've had very, very poor attachments while growing up. What is sometimes termed as biparental failure. They have not had the ability or the opportunity to form adequate emotional attachments as children or infants with at least one parent. If that does not happen, those are some of the patients who develop the chronic emptiness feeling. And chronic emptiness is again highly correlated with death by suicide. So it's an important symptom to work with. How do you work with? Is psychotherapy. Again, if you are able to provide at least one reparative psychological attachment over a period of few years, that can heal the emptiness to a great extent. In the absence of which, patients are going to fill that emptiness bucket with substance use, with impulsivity, with anger, with self-injury, with repeated problematic relationships.
Thank
Hope
you.
that answered that question.
Yeah, and related to that, there is, I think, Dr. Prashant was asking, is there, he's given different patients and how they have, behaved and symptoms that he has described, and he's wondering whether it is the underlying attention deficit which is present in these scenarios, which may become the cause of the helplessness of depression. So do you think that it is the attention that is the problem and therefore that is leading to all of this, or is it more the pain and the emptiness which we presume is leading to all of this? I think Sir has answered that, but we'll ask him to expand a little bit more on that.
Sure. The science of cognitive dysfunctions in borderline personality disorder is relatively new, and it's a very interesting field. We still don't have the answers. There are attention deficits in borderline personality disorder, no doubt. Now, Is it caused by the chronic symptoms of BPD? It is the chicken or the egg. So that question is not answered yet. So, but however, we do see cognitive disturbances in BPD. So that is clearly an association. But whether that can replace, that can cause some of the symptoms that you just mentioned, probably no.
So, you said one of the important things was psychoeducating the patient and the relatives. So when we are talking to the relatives, what would be some important points that we should not miss is what Dr. Chinmay is asking.
Look, I often give that car analogy. That's my favorite analogy to tell patients, tell the families, telling them that, look, your daughter or son, they're trying to do the best they can to cope with the problems they have. They're not deliberately doing it. They're not manipulating. I wish they were good at manipulation, because if they were really good at manipulation, you wouldn't be able to see through. But they do such a poor job of manipulation. All of us can see through the manipulation. They, in fact, have very poor interpersonal skills. They're actually trying to deal with their symptoms in a desperate manner, which appears like manipulation to most of us. So also we would need to tell them that it is a mental illness. It's a disorder of the brain and the mind. Unfortunately, there is no medicines to treat that. We can give you some medicines, but those medicines are not going to bring about any urgent changes. It takes time. It takes about 1 to 2 years for them to get well. And until then, we need to keep them alive and keep them safe. And there are 10% of them are going to die. Hopefully your daughter is not one of them. Son is not one of them. We'll do our best to prevent that. And meanwhile, what parents can do is not to invalidate them. See, one of the mantras in treating borderline personality disorder is to look for opportunities to validate. Every single session that we have with the person with BPD, we are looking for opportunities to validate. We are looking for opportunities to teach 1 or 2 skills, to regulate their emotions, to regulate their interpersonal difficulties, or life as a whole. So that's the same approach we are asking for of our families, to try and not invalidate them, try and look for opportunities to validate them and encourage the self-agency. And of course, if they're acutely suicidal, I teach them how to differentiate between acute suicidal behaviors and chronic suicidal behaviors. And if they're really in danger, of course, they need to do everything to save them. If they're not in danger, not to excessively reinforce their behaviors. That analogy that you provided, Henel Shaw, that a person comes to the clinic threatening that they're going to cut themselves or they're going to take an overdose. What do we do? Of course, the first time we'll say, hey, look, so I would probably in that situation say, looks like you're in a lot of pain. It looks like you're very distressed. You are even thinking about killing yourself. But let's sit down and have a chat. What's happening to you? And then if really hospitalization is the only thing that the patient is demanding, I might consider hospitalization, but I would tell the person, look, I don't have a magic medicines to give you to make you feel better. It's going to take a long time. But if you want to stay for a day or two, have a chat to explore what's really happening to you, let's do it. But if you repeatedly do the same thing again and again, I won't be able to help. The hospitalization is not the solution. So it's about trying to bring the person on our side gradually.
And to trust you. I think, the matter of trust development in a relationship with a patient with bipolar, with borderline personality is so important. Like I'm seeing some of these, aunt and niece, and I have another patient where they're 2 sisters. So when you see them generational also, you realize that the trust is such an important factor, and their faith in you is what gets them back to you. And I think that with that therapeutic relationship plays a crucial role. And one important question that Chitra has asked and has asked again is that how do you really elicit this lack of identity, and what kind of answers will that person give which will make me realize that this is lack of identity?
So basically they would tell you that I am nobody. I don't know who I am. It's a very common answer. I don't know who I am. So for all of us, if you ask any one of us, give a hypothetical question and ask them, how do you think you're going to answer if this question is posed to you? Most of us would have a sense of what we would say. People with BPD would say, I don't know what I'm going to say in the moment, often. So they don't have a sense of who they are. And often they would try and mimic somebody else. It's very common for BPD patients to say that behave like a older sister or a neighbor or a friend or someone whom they have seen in a movie. Repeatedly, they tend to take on the identities of other people, behave like them, desperately trying to fill a sense of identity. So a very simple question as to, do you feel comfortable with yourself? Do you have a sense of who you are? Often it would elicit some of the answers.
And Chitra, you've also asked, how do you really address this constant feeling of emptiness? And so, like as Dr. Rao said, they have to have, live the life. So they have to have something that they look forward to, that they get up and want to do things. So I think one of the things that I have also found very useful is them to having something to live for, something focus of attention, whether it is their family, whether it is a cause, and very often sometimes I try to get them introduced to some cause, so which they feel, passionate about, and then they want to do things for, sometimes it may be activist cause, sometimes it may be helping a charitable organization, maybe a religious cause, but having something to do, and to go forward and doing that would be useful. Is there anything else that you would suggest, Dr. Rao?
I think, Professor Shaw, you answered it beautifully well.
Thank you. Yes, the slides will be available for everybody. If it's on the website, and all these slides will be shared for you. So, we will also ask Dr. Rao whether any books that people should read, or how you did mention go to the website and also look at, they've given how therapy can be done. And I think they've made it doable for us. So if we go to that website and, look at it, that will also be helpful. There is Dr. Prashant who's asking whether we can use zuclopenthixol depot. It's his personal experience with a couple of patients where he's used zuclopenthixol. What is your comments on that?
Look, there is one paper suggesting that zuclopenthixol, in fact, flupentixol, there is a paper. Look, I've not found it useful because none of the antipsychotics seems to help. If in a specific patient, if you're finding zuclopenthixol useful, by all means, use it. But probably you should educate the patient saying that it is a non-specific indication, and take the consent, because you don't want to be sued by the patients if they develop tardive dyskinesia later on. There's no evidence base, but I have heard at least a couple of my other colleagues say that they have found flupentixol, zuclopenthixol somewhat helpful, especially if patients have micropsychotic symptoms. Some of our patients with BPD will have psychotic symptoms, brief lasting, transient psychotic symptoms, almost always stress-induced, in the form of transient hallucinatory phenomena or transient paranoid phenomena. If they do have that, low dose of antipsychotics may be helpful, at least for short periods of time.
Madhusudan is asking, is borderline personality along the spectrum for bipolar? And what is your take on that, sir?
Look, that's again been proposed. In fact, Akiskal called borderline personality disorder as a verb in search of a noun, an adjective in search of a noun. Look, that is again a common misunderstanding. BPD is not a type of bipolar disorder. It's an entirely different disorder. It doesn't respond to biological therapies.
But I think one of the most reassuring things that you have said today is, one is you've drawn out the facts that, if you look at the numbers and you look at the outcome is good. The second thing that you have drawn out and made it very important is that it's not rocket science. I think all of us have, by seeing this, mentalizing, ACT or looking at any of these therapies, we have been taught to think that, we are not qualified to do it. And Dr. Rao has said that it is possible for people who have not been trained in psychotherapy to yet do this. He has given us websites where we can go. It has been, broken down into small pieces and chunks of information and, those 10 weeks of therapy. So there is a hope for all of us that in our practices also, we can kind of take help from there, and these slides will be available, Rashmin, I'm sure, on the website, and we can go and look at it, and from there take the cross references and look at it and figure out how we can go ahead from there. That was a very reassuring, really. I think the most important thing that I feel is that people avoid trying to treat bipolar disorder, And I know when, as residents, we used to discuss, I hope he doesn't come on my call, then comes on your call day. Dr. Rao has kind of lifted the lid on that and said, look, even if you're a resident for 3 years, you can see by the end of 3 years, he or she will be better. So here's the goal for all of us, to be able to understand bipolar better, to think of simple things like having a good therapeutic relationship, validating the person, minimal use of medications or admissions, trying to improving our psychotherapeutic skills, and yes, all of us can do it. That was a wonderful message. And I think that's almost come to the end of the questions. And I see Chinmay has put one more thing. What he has said is, okay, interpersonal conflicts are a common entity. Are we allowed to point out to the client about the toxic nature, especially in India, where going against family might be a non-conducive in the long-term prognosis of persons with borderline personality? So how do we kind of tell the family that, and how do we kind of get into that?
We need with PTP, everything needs to be discussed clearly. If they're actually, the way they're interacting with their families is counterproductive, is causing them harm, of course we need to point out to them, but it needs to be done in a way which is not invalidating. And we need to be able to work with the person to realize it themselves. Because if we take a paternalistic, patronizing attitude and tell them, okay, this is, look, the way you're interacting with your family is not correct, it's not going to be helpful, that's not going to go very well. Because I'm sure their parents would have told them numerous times. They become one of their parents in that sense. So our job is to really keep asking them questions as to, okay, your parents are behaving like this, and that's what is causing you distress. But that must feel very awful for you. Because if someone is really, if your dad is behaving or mom is behaving like that with you, it's going to distress you. I can see your point of view. Also, why do you think your dad is behaving that way? Why do you think your mom is doing this? When trying to get the persons to understand why the other person is behaving in a certain way, and then getting them to put themselves in their shoes and try and see from their point of view. It's really that sort of a psychological work we're looking for. So, of course, we need to point out.
Really, that's really clear explanations. And I thank you once again for a very, very lucid, very, very clear. And I think the hope that you have generated in all the people who are here, that in your practice, in your residency, in your wherever clinics that you are, you will be able to treat patients with a borderline personality disorder. Not only that, you will see good outcomes with it. So this is a very, very clear and hopeful message that has been given by Dr. Sathya Rao. Thank you so much, sir, for that. And we will be going and seeing those slides again, and the references and the guidelines and the therapeutic work that you have talked about. So that was really wonderful. I thank you once again for being with us and spending this hour clarifying all our doubts. I thank all the audience for their interactions. And again, once again, thank Rashmin and for having us here. And let's send it back to him to end the session. Rashmin, all over again to you.
Thank you. Thank you very much, Dr. Hinal and Absolutely brilliant, Dr. Rao. I have no words. This has been one of the most challenging disorders. Like you rightly said, some people are very averse and little trigger shy when it comes to treating borderline personality patients, and it can be a little confounding for us, not primarily because of the fact that we may not understand it well, but because we can do so little with our limited understanding and knowledge. And today was a great day for us to be able to bridge that gap about our lack of understanding and our reservations in handling these patients. So it was in that sense a very, very positive push in the right direction. And we hope to have you back with us on some other occasion to share with us your wisdom and your teachings. But I'm very grateful for you to have taken this time. And I know it's close to midnight back in Melbourne where you are at. So we are very, very grateful for you to have spared the time. And I'm sure all of us will look back fondly on this talk and revisit these deliberations on the website. The lecture will be uploaded very soon in the video format, and the slides will also be uploaded in a couple of hours from now. Probably they already might be. So thank you all once again. And of course, a big thank you to all the audience who so actively participated. It is your participation which drives us to keep bringing these talks and these lectures to all the postgraduate students, and not just postgraduate anymore, because like Hinal rightly said, a lot of consultants are also revisiting their old postgraduate days to kind of refresh their skills and also pick up some new ones along the way. So thank you all for your participation. And of course, it would be remiss on my part to not thank Sun Pharma for their continued support. It's been a great evening, and I wish you all a good evening ahead. And thank you once again, Dr. Hinal and Dr. Sathya Rao. Very, very indebted to the both of you. Thank you all.
Thank you.
Thank you.